So, what are the complications you can have during these types of tracheostomy? Generally, in a high tracheostomy, because you are going at the level of the first ring, you can have an injury and causing a complete stenosis of the laryngeal cartilage. So, that can be related to a high tracheostomy. Normally, in a mid tracheostomy, you can have an injury to the level, to the injury at the level of your isthmus or at the level of your thyroid. But this can be again gently retracted, and then you can plan for a tracheostomy. Low tracheostomy, the commonest complication is injury to the lung. So, you can have a pneumothorax. So, sometimes when you do a little low tracheostomy, you can have an injury to the apical pleura, which can cause a pneumothorax, and this is commonly seen when you do a pediatric or a tracheostomy for a children. So, this is how you normally plan for a tracheostomy. As I said, this is the normal thing. At the level of the second, third, you plan for a normal tracheostomy. Anything above, you take it as high, or anything down, you plan or it's cause a low tracheostomy. So, how is the patient position? This is the normal position for a patient for a tracheostomy. You keep a sandbag down so that you get a extension and you get your trachea in front. So, patient lies in a supine with a pillow or a sandbag under the shoulders, so that your neck is extended and your trachea is brought forward, so that it is much more easier to do a tracheostomy. Definitely, before any kind of a surgical intervention or procedure, you would like to do a concern. You will definitely get to a concern. If a conscious patient, you can get it from the patient, or an unconscious, or he's been on a ventilator, definitely you have to get a concern from the patient's attendant. So, these are the basic instruments which are required for doing a tracheostomy. So, you have a syringe with a local for an infiltration, a 15 blade which is normally required, and a retractors, either a Alice or a Langenbach's retractor, and then you have a thyroid hook, and then before you make an incision on the trachea, you would like preferably to have a 11 blade, and once you make an incision, then you would like to use a tracheal dilator to dilate and put in the tube, and later on you might have to suture the skin if required. So, again coming back, so this is how you put a patient to position so that you anteriorize the trachea and much more easier for doing a tracheostomy. Obviously, an adequate lighting is required for a tracheostomy, and usually you will like to have an anesthetist next to you in case to check in for an airway, or if there is any kind of a collapse to do an emergency intubation which might be required, and obviously a nursing assistant to have a support you during a tracheostomy. So, how do you do a tracheostomy? Once you make the area sterile, you infiltrate with xylocaine with adrenaline so that it minimizes the bleeding in that area of where you want to do an incision. And an horizontal incision is always required when you plan for a elective tracheostomy. As we discussed before, in case of a emergency procedures, you would like to do a vertical incision. Otherwise, generally you have an horizontal incision. So, once you make an incision using a 15 blade, then you have your subcutaneous tissue which is retracted. Then you identify the strap muscles and you retract the strap muscles, and sometimes you might have a huge thyroid which might be retracted or hooked up. So, once your thyroid is hooked up, you would have an exposed pretracheal fascia in the center. So, once you identify the pretracheal fascia, you would obviously see the tracheal rings there. So, once you identify the tracheal rings and your site of making an opening, you would like to inject some xylocaine, preferably 4%, so that the patient does not have any cough. I am talking about this in an elective procedure or patient who is not in a intubated state. So, you would like to put some 4% so that it gives some numbness and patient's cough reflex is suppressed, and then using a 11 blade you make a horizontal cut over the trachea. Once this is done, then you dilate the trachea and then preferably put in the tracheostomy tube inside, and you check for the airway. So, once your tube is in, you would like to see for airway, whether both sides the airway is adequately ventilated on both sides of the lungs. Once this is done, if you have a EtCO2, you would like to check for the EtCO2 which is functioning and see whether your airway or your tracheostomy tube is in position. Once everything is confirmed, then you would like to make a suturing of the tracheostomy tube to the skin so that it doesn't get slipped away, and you can also make some skin sutures if required based on the size of your skin incision.